Thanks a lot. Yeah, so I'm going to be talking about current indications for angioplasty and stenting of intracranial atherosclerotic disease, similar to the case that we just looked at. Trying to figure out how to go forward with this thing. Oh, I guess I can hit this. Yeah, so if we look at the randomized controlled trial data that we have for patients who are traditionally targeted for intracranial angioplasty and stenting, we're looking at cases very much like the case we just saw, so greater than 70% stenosis in patients who are symptomatic with either a TIA or stroke. And to date, all the available randomized controlled data that we have demonstrated an increased risk of stroke and death in patients undergoing intervention. So the definitive trial on this topic was the Samprass Trial, which was published quite a while back. First paper was in the New England Journal of Medicine. And in this trial, we compared angioplasty and stenting with the Wingspan device, the Wingspan system, the system that you just saw used, plus aggressive medical management. And we compared that group to the aggressive medical management by itself. The inclusion criteria were patients with 70 to 99% stenosis who presented with a non-disabling stroke, meaning their modified Rankin score at baseline was 3 or better, so they were able to ambulate independently. And that event had to be within the previous 30 days. And so this was chosen because this was the highest risk population in the WASID study, which looked at medical management of intracranial atherosclerotic disease. So we wanted to choose the patients who were at highest risk of recurrent events because we could have the greatest effect size if angioplasty and stenting was in fact successful. So we're asking the question, a patient like this who's got, say, a 90% recently symptomatic intracranial stenosis, what is the best treatment for this patient, medical management or angioplasty and stenting? And what we saw is that the angioplasty and stenting actually had a much higher event rate than medical management by itself. And you can see that almost all of this was accrued within the first 30 days. So the periprocedural morbidity and mortality related to angioplasty and stenting far exceeded what we saw in the medical management group. And you can see when we blow up this sort of periprocedural period here that there's a huge discrepancy between the angioplasty and stenting group and the medical management group. And when we look at the actual numbers, this difference is quite stark. You can see an absolute risk reduction of 8.9% in patients who were treated medically versus patients who were treated with angioplasty and stenting. So almost a 50% periprocedural event rate with the angioplasty and stenting and only a 6% rate in the medical management arm. So if we look at periprocedural fatal strokes, 5 of 213 in the stenting group, so 2.3% of patients had a fatal stroke, either hemorrhagic or ischemic, if they underwent angioplasty and stenting. No fatalities in the aggressive medical management group. If we look at hemorrhagic stroke, 13 of 213 patients, so 6.1% in the angioplasty and stenting group experienced a hemorrhagic stroke in the periprocedural period. There were none of these in the medical management group. And so these are some examples of hemorrhagic stroke, and so you can see these are fairly significant events that we were talking about with parenchymal hemorrhages and significant subarachnoid hemorrhages, some of which were, again, fatal in this group. Periprocedural ischemic strokes occurred in 10% of the patients, and most of the time, 3/4 of the time, these were perforator infarcts. These were really some of the most frustrating complications that we had. So this is a case, high-grade basilar stenosis symptomatic, beautiful result with the angioplasty and stenting. However, the patient wakes up with a significant deficit, and you can see a perforator infarct right at the level of the angioplasty and stenting. So probably atherosclerotic plaque being snowplowed over perforators in this region, creating, again, an event during the treatment. So even though the treatment technically was fine, it was just a failure of this modality. And so when we followed these patients out, the second paper was published in Lancet in 2013. Another frustrating thing is that if you did have angioplasty and stenting, so you get through the periprocedural event and you come out of that okay, it really didn't reduce your risk of stroke as we followed these patients forward. So the medical management arm and the angioplasty and stenting arm look almost exactly the same in terms of the accrued event rates after the periprocedural period, meaning that if you successfully had angioplasty and stenting, it wasn't like in that case it markedly reduced your rates of events afterwards. So the curves basically remain parallel as they go out, and there's not really any catch-up that's occurring between the medical management event rates and the angioplasty and stenting rates. When we looked at all the subtypes of patients and broke them out, there was no benefit of angioplasty and stenting in any subtype of patient. Similar trial, the VISIT trial, was using a different stenting device. They had similar entrance criteria and similar medical management to Samprass. So this, again, was a different study using a balloon expandable stent comparing angioplasty and stenting to medical management. And this, again, enrollment was stopped early as it was in Samprass because of the very high peri-procedural event rate. Their rate was actually substantially higher than what we saw in Samprass, 26% rate of either ischemic or hemorrhagic stroke in the angioplasty and stenting arm. And if you look at any stroke 30 days or stroke in the territory up to a year, that increased to 43.1% in the angioplasty and stenting arm versus only 9.4% in the medical management group, where the number needed to harm with balloon-mounted angioplasty and stenting in this study was only 3. So again, a marked difference in favor of medical management over angioplasty and stenting. So what do I conclude from this? Well, angioplasty and stenting looks like it's a harmful procedure in the short term, so less than 30 days, with markedly higher event rates than aggressive medical management in these patients. And then in the long term, if you even get through the procedure and you do well, so you have a successful angioplasty and stenting, your vessel's now open, your event rates really weren't very different than the event rates in the medical management arm. So the long-term benefit of successful angioplasty and stenting really doesn't seem to be manifest in these patients as well. Aggressive medical management with dual antiplatelet therapy and aggressive statin therapy actually is very effective, and I see quite a high number of patients in my own clinic with high-grade symptomatic intracranial atherosclerotic disease and in clinical follow-up, and really very few of them have events at follow-up, and that's depicted here. So the medical event rate that we projected from WASID, when we changed the therapy from Coumadin or high-dose aspirin to dual antiplatelet therapy and aggressive management with a statin to get the LDL less than 70, you can see that the actual medical event rate was halved. And so really the success story of Samprass was that the medical management that we used in Samprass was so much more effective than the previous medical management in preventing events. So aggressive medical management is the treatment of choice in these patients. And so who do I do angioplasty and stenting for? So patients who have very high-grade intracranial stenosis and have recurrent hard TIA or actual stroke events in the distribution of the vessel, despite maximal medical therapy with an effective dual antiplatelet regimen and an LDL under 70 and good blood pressure control. The occasional patient with a posterior circulation stenosis who's position dependent, meaning the patient can't even sit up without having TIAs. Occasionally we'll see a patient like that. It's extremely rare, maybe 1 or 2 of these people every year or so. And then the most common time I'm performing angioplasty and stenting is in the context of a thrombectomy, where you do a thrombectomy and there's still a high-grade underlying stenosis that is precluding continued patency of the vessel. So if we did have another technology where we could do an RCT, it would be very difficult to do this with the medical event rate being 12% over a year. To get a substantial reduction in that medical event rate with any kind of technology would require an absolutely huge trial. So even if you could have, say, a 5% absolute risk reduction, that trial is like an 800, 900 patient trial of Samprass type patients. So it'd be very difficult to do a trial like that because of the number of patients we'd need. And if we could find an even higher risk group for early events, potentially you could do a trial with those patients, but those patients start to become exceedingly rare, where you're starting to drill down on that pie chart of patients with symptomatic intracranial athero, so it's going to be very difficult to recruit patients like this into a trial. Thank you. That's all I have.